Hi, everyone. This is Shabir Musa. I'm a family physician in South Africa and the president of Wonka Africa, as well as the facilitator for the Afro-PHC. We have people from within the space of Botswana who are willing to share with us. We have Mpo, who is the chairperson of the Association of Family Physicians in Botswana, who's going to share with us, and she's going to introduce her colleagues, Marelise and Sandra. We are very pleased to be able to share what is going on in various parts of Africa. I think in Africa, the epidemic is in fact growing considerably, and we are aware of the fact that hotspot still remains in South Africa, but the neighboring countries in South Africa, in Southern Africa, face the grave threat of that epidemic being transported to them. In Botswana, the cases are actually growing also exponentially in the last few days, but I think that's more detail is going to be shared by our panel. Paul, thank you very much for joining us. If you don't mind coming onto the conference and letting us see you and hear you. And if you can also introduce your colleagues, Sandra and Marelise, as you go. Dr. Mpape, welcome.
Hello. Hello, everyone.
Can hear you very well.
Dr.
Thank you.
Okay. My name is Dr. Mpape. I'm a family medicine resident in the University of Botswana. And as it has already been said, also the chair of the Botswana Association of Family Physicians. Hello? Hello?
Yes, we can hear you very well, Paul. Don't worry. Carry on. We hear.
All right. Okay. And I'm the chair of the Botswana Association of Family Physicians, which is a fairly new association, and they are also members of Wonka. And as it has already been mentioned, family medicine is fairly a new specialist training in Botswana, but we've been having family medicine specialists even before the training, which started around 2012, around there in Botswana. So together with me is Dr. Sandra Maripe and Dr. Marelise Gonzalez. I think they will just get a few minutes to introduce themselves, if that's okay. Dr. Sandra? Yeah. Dr. Maripe?
Let me help you to
I'm here.
Go ahead. Go ahead, Marelise.
Okay, my name is Marelise Gonzalez. Thank you for inviting to this meeting. I'm a family physician by specialty. I graduated as a medical doctor in 1997 and as a family physician in 2001 in Cuba. I've been having the pleasure to be in Botswana for the past 18 years. So it's been very good to be part of this team today to share part of our job in the private sector. Thank you very much.
Thank you very well. Welcome. Sandra?
Good afternoon, everyone.
Yes, Sandra, we can hear you. If you can just introduce yourself.
Okay.
Sorry, Sorry, Sandra, if you can just unmute yourself. There we are. Go ahead, Sandra. Go ahead, Sandra.
Okay, I'm Dr. Sandra.
I think Sandra's struggling with the mute button. Sandra, don't touch the screen, just introduce yourself.
Okay, I'm Dr. Sandra. I'm also a graduate from the University of Botswana. I graduated 2 years ago as a family physician, and I'm currently practicing in a small village in the northwest part of Botswana called Maung, and also the secretary for the Family Physician Association of Botswana. And I'm glad to be part of this meeting.
Welcome, great. Mpo, thank you very much for joining us, all of you. Mpo, you can proceed.
Okay, we're just gonna give a brief presentation on our response in Botswana to COVID-19. And moving on. I think I'm having a problem there with moving the slides.
Okay, if you press as normal, if you just move your slides forward, should move.
Okay.
There you go. There you go. Good.
So I'm just gonna give an overview of Botswana. It's a country in southern part of Africa, just above South Africa. It has a population of 2.3 million. That's from the last population census of 2011, and population surveillance. Most people live in the eastern part of the country, and Gaborone is the capital city.
Mm-hmm.
I think I'm having a problem again.
I'm sure you'll get it right. I think it's coming along. There we are.
Yeah. So as we already have spoken, we already know COVID-19 is a disease caused by SARS-CoV-2, and its first case was identified and detected in Wuhan in China in December 2019, which later World Health Organization declared it as an international public health emergency around the end of January 2020, and around 11th of March in 2020, it was declared a pandemic. So this actually sensitized different countries to actually get ready to prepare for management of COVID-19.
True.
Impact of COVID-19, it actually disrupted many lives globally. We saw people's health being affected in different ways. Those that have been living with chronic illnesses being in danger of actually losing their lives to COVID-19. And it also, with its processes of managing it, we saw people and countries having to shut down, actually affecting the socio-economic status of countries, individuals, businesses, and the whole world in general. It also affected academic processes as schools had to shut down, universities had to shut down. Some countries which were able to resort to online training, but in some areas, like, for example, some parts of Botswana, it was very difficult for people to move on because online teaching is not something that is actually well practiced in some countries.
Definitely a disruption in all our lives.
Yes.
There you go.
Okay. What in Botswana, after World Health Organization actually declared COVID-19 as a pandemic, like any other country, Botswana also started its preparations. So there was national preparation as early March, the president moved on to brief the country, and then they went on to form a presidential task force, which was actually an advisory to the president, made up of the Minister of Health and other doctors in high positions in the Ministry of Health and also in the academic field. So they brought up a task force which will be actually advising the country and advising the president on how to go about management of COVID-19 should we have cases, and how we could prevent even going on to having cases. And then there was implementation of restrictions of travel in and out of the country. So we saw that most of the international official trips being cancelled and put on hold. And we saw limitation of people coming into the country. If you come into the country, you might have been subjected to have to self-isolate for some time before you can actually mix with the population. And then what came up next was the screening of people as they come into the country at point of entry. If you get to the airport, they would actually take your temperature and you will have a questionnaire where they will ask you if you have any symptoms that could actually say maybe you might be having COVID-19. And also implementation of mandatory quarantine of travelers from high-risk areas. These were areas where COVID-19 was already there and people were traveling from there. So these were taken as high-risk areas and people were to go onto mandatory quarantine for 14 days, where they will be monitoring themselves and also with some healthcare workers around to ensure that anyone who develops symptoms or is not well can be taken care of, and also done tests for coronavirus. So there was also setting up of quarantine sites. We saw hotels in Botswana giving up their places to the government so that it can use this as quarantine sites for those people who are traveling from other countries, especially high-risk areas, and being quarantined in those sites. And also the government set up some isolation and case management sites so that if we have any case that is confirmed as COVID-19, it can be, the person can be isolated in those sites and managed appropriately.
It's just kind of the typical thing that has been happening overall. So I think your slides maybe are moving the transitions rather slow. So let's wait for it as it changes over. So this is kind of typical of what's happened in most countries, I imagine.
Okay, that comes up a list of isolation and care management centers that the government set up. It was actually a number of places in different areas of Botswana, just to cover the whole area of Botswana, so that when somebody is in the northern part of the country, they would either be isolated in Maung or Kasane. If they're around Gaborone, there's a hospital there in Gaborone that was also a new hospital that is due to open. It was set up, Sekitumile Masire Teaching Hospital, where I was actually placed to be part of the team managing COVID-19. And Dr. Sandra was in Maung area, and that's where she was based. And as you can see, it's a wide range of places there, and they were actually spread around Botswana so that once we have a case, we wouldn't have to have our clients moving too far across the country for isolation. So moving on, what happened with in Botswana is that we had our first cases, which were reported on the 30th of March in 2020. And we had about 3 cases which were reported on that day. and all of them were imported cases. There were cases from people who had actually traveled to areas which were termed high risk. And on the 1st of April, we recorded our first death from COVID-19. And the Director of Health Sciences at the Ministry of Health actually declared a public health emergency. And the country was mobilized into moving forward in terms of COVID-19 management. And also the president announced that there will be lockdown, which was due to start on the 2nd of April in 2020. So this actually happened on the 2nd of April 2020. We saw the whole of Botswana getting into lockdown, where almost everyone had to stay at home. Schools had closed actually a week earlier before the 2nd of April. And only those who were actually providing essential services were the ones who were allowed to go and move around so that they can help in the management of COVID-19. This included healthcare workers. It included security officers from the army, the police. It included those who were working in shops so that people can actually, if get a chance, can get food from the shops. And then there was also the president called on the cabinet, the members of parliament, and then there was a state of emergency, which was declared a week later after the lockdown. And this state of emergency is expected to last about 6 months. So that's basically what happened. And during this lockdown, the country was divided into zonal areas, where these zones were actually to help should we have more cases in one area, then it would mean that that area can actually be shut down on its own, allow for the economy to open in other parts of the country where maybe we might not be having cases.
True.
So as it stands on the 17th of June, we had a number of 79 confirmed cases in total from the first one that was actually the first ones that were reported. We had a total of confirmed 79. We've had 25 recoveries so far. And of the 79, most of them were identified or detected at point of entry at the borders. And they were actually, with communication with their countries of origin, they were transferred back to their own countries. And we had on the 17th of June, 4 active cases. And we had only 1 death that we recorded at the beginning.
So it's mostly in imported infections.
It mostly imported infections. Yes, at the somewhere around mid-April, we had a few local cases, and all of our cases, fortunately, except for the one who demised, fortunately, most of them had mild cases, mild symptoms, and some of them actually were asymptomatic, and most of them have recovered. We never really had anyone becoming unstable or anything like that.
So the local transmission has not been very much.
It hasn't been much. Yeah, it hasn't been.
No problem, Karen.
Okay. So in Botswana, when we talking of primary health care, usually it's we have what we call district health management teams. So those are DHMTs. So that's where most of primary health care is actually practiced. That is where we have general doctors working there. We have nurses. We have family physicians working in these district health management teams. And we have a number of them where they are actually headed by family physicians. And we also have family physicians in private sector. We also are working hand in hand with family medicine residents who, when they are doing their training at UB, they are actually placed at clinics at district hospitals and primary hospitals where primary healthcare is actually practiced. So the district health management teams, or DHMTs, were actually the ones which were tasked with implementation of COVID-19 prevention and control strategies. So working together with family medicine and public health, they were to facilitate primary care delivery in terms of management of COVID-19. Like I have mentioned earlier, family medicine is a new specialty in training in Botswana at the University of Botswana, but there has been family physicians before, actually placed in different parts of the country. There are 3 major training sites, one in Gaborone where I'm actually based, another one is in Maung where Dr. Sandra is based, and there's another one also in Mahalape. And we have family physicians as heads of DHMTs, and also we have family physicians in the private sector, like we have Dr. Marilyn Gonzalez in the private sector.
Okay.
So, like I mentioned earlier, the country was actually divided into zonal areas. So,
was that along the line of the DHMTs? So these are DHMTs.
the zones were not in line with DHMTs. They were actually bigger than DHMTs, but the DHMTs could actually come together and work in the zones. The zones were actually advisory, like from the task force. And they also, I think, were looking at the neighboring countries and the borders. So, like for example, most of the Gaborone zone there, it included most of the South African borders that many people use to get to Botswana. And when they first came up with the zones, they were looking at where we had cases already. So they were not actually according to the DHMTs. So we can see Gaborone there. It's a big zone, and this was to assist in case we get cases crowded in one zone. It would actually help if with locking down, making a zonal lockdown, and then opening other parts of the country. So that was the main reason why they divided the country into zones. So Gaborone is where I said I'm based now. Okay, what is the role main of family medicine in collaboration with the Greater Gaborone DHMT? Okay, for the information, we decided to pick 2 DHMTs, that is Gaborone where I am, and then also Maung where Dr. Sandra is. She will talk a bit about her district, what they did there. And then Dr. Merlis will give us a brief on what they did in the private sector as family physician.
Good.
Yeah. So in Gaborone, Greater Gaborone DHMT, where I am, we were tasked with setting up of a screening clinic at Sekitumile Masira Teaching Hospital, which I said is a new teaching hospital, which is due to open, affiliated with the University of Botswana. So we are tasked with setting up a screening clinic there. This is, there was actually nothing in place there. We had to actually work to put things together. This was termed an upper respiratory tract infection or flu clinic. So it was to be set up for screening and testing of suspected cases. And suspected cases were all those who would be presenting with upper respiratory tract infection symptoms, that those who would be presenting with respiratory symptoms and having had traveled to high-risk areas or having had contact with a confirmed case. So they were actually those that we would determine suspects.
What sort of symptoms, if I may ask? Which specific symptoms?
It was mainly sore throat, fever. It's fever, sore throat, cough, and such. There's sneezing, sort of respiratory symptoms, even or going on to those who would be coming maybe with shortness of breath, which might not necessarily be upper respiratory, but anyone who showed respiratory symptoms, mainly fever, sore throat, cough, shortness of breath. Those are the ones who actually would, in conjunction with their history of travel to high-risk areas, or having been in contact with someone who is confirmed to be COVID-19 positive.
No problem.
Mm. So we started off with, as family physicians, we started off with demarcation of working areas. We actually had a testing area for those who would be presenting with symptoms. And then we had an area where we would be screening those who actually present without symptoms. And those ones will be the ones who have had a history of travel to high-risk areas, and they are due for testing. Because as we know, they would be quarantined for some time, about 14 days. And at around day 10, they would actually be coming for testing, or we will have to go to their homes to do testing or to quarantine sites. So family physicians were also involved in training of staff on infection prevention and control measures, together with the infection control nurse, and also safety, health, and environmental officers. So basically, we were training people on PPE usage, implementing World Health Organization guidelines on which PPE, and also how to put on the PPE, how to take off the PPE. So those are the things that we actually involved in doing. And also we trained healthcare workers on who will be responsible for taking collection of swabs. So we actually trained them how to do that, and also proper handling of specimens so that they go to the lab in good condition.
So whilst this was transitioning, did you all screen at the gate those who have symptoms and those who don't, and then allow people in?
Okay, what was happening actually was that the nation was advised that if you are at home and you feel that you have any symptoms, you will be, there's a call center actually even now that is set up. So it's an emergency service, health service. So you call that number and you tell them, you would tell them that I have this and this and that, and maybe I've traveled to here and there, and then they will actually go and take you from your home and bring you to the screening clinic. Yes, that was what was happening initially. Even now, it's still like that. If you have symptoms that and you highly suspect that it's COVID-19, you have to phone. You don't have to go directly to the clinic. If you are forced to go directly to the clinic, you should inform the clinic that you are coming, so that they are ready for you when you get there. But screening is done at the gate for those even in other health facilities. Screening is done at the clinic. They take the temperature, they sanitize, and also some areas there's water there for people to wash hands.
Good, wonderful.
Okay, so we were also involved in actively taking all oropharyngeal and nasopharyngeal swabs for testing. We also, as clients, like I said, they would come in through the emergency health services. We would have to arrange for them to be taken to quarantine sites. And also as family medicine, we would give out results to clients, counsel them and give them results. And also, but for those that were positive, we were confirmed, there would be a team that would actually go to them and give them the results, and then they will be taken to the isolation center. And then we, as family physicians, were working as the link between the lab, the quarantine sites and the isolation center, so that we don't have a backlog of things without people getting their results on time, or people not being tested at the appointed time, which is around 10 days post-quarantine. And also ensuring that those who have already been confirmed are actually retested at the appropriate time.
So while the slide is changing, do you have challenges with the results, turnaround times of results?
Initially, it was taking longer because the first ones we were testing in South Africa until we were accredited, until our lab was accredited.
Mm-hmm.
So the longest currently has been about 72 hours.
Oh,
so
really?
anytime after 24 hours to 72 hours, that's the turnaround time.
Well done, well done. That's a big improvement on South Africa, for example. Very good.
So at the quarantine site, we had family medicine residents being placed there as resident doctors at this quarantine site. They would actually be doing facilitating the screening for COVID-19 and also caring for those with chronic diseases, because some of them were just maybe traveling from those parts, different countries, getting into Botswana, and then they will be put into quarantine sites, and some will be running out of medication, some would be, so they would need someone to be there to assist from the medical side, and family medicine residents had been there together with other doctors in the DHMT to actually assist those with chronic disease, so that their diseases are managed properly. And we're also providing psychological support. Some people were very distressed and they needed someone to actually talk to them. We're doing screening and collecting of swabs for testing, and also collaboration with the contact tracing team. Some were taken from homes with symptoms, and then after we tested them, they would be put in quarantine sites. So while they were there, the contact tracing team would be collaborating with us, so that the people whom they have come into contact with can actually be also assessed at their homes.
So while you're transitioning to the next slide, was there a strong community health worker presence involved in this contact tracing? If you don't mind sharing a little bit of detail.
I didn't get the question.
Do you have community health workers quite strongly involved in the contact tracing and in your work as a family physician? Community health workers.
Yes. We have community health nurses, which are part of the DHMT. Yes, so they were the ones who were at the head of of contact tracing. So as we went on, then I think you've seen the slide where I mentioned that most of the cases that we reported, moving onwards around the 17th of June, you could see that we had about 49 people being transferred out to their country. So we realized that there was, we were not getting more cases within the country. So very limited local transmission. And most of the cases that we're getting, we're actually getting from outside. And there was a setup that maybe people should be tested at the point of entry. So we were deployed as family physicians, as family medicine residents in Gaborone to Tlokweng border to do screening and testing there. So and that is where we are also currently based. So together with Sekitumile Masire, we will be doing shifts in Sekitumile Masire and then also in at the border, doing testing and screening there. We also give education on IPC measures to clients who are traveling, and most of them will be truck drivers who are bringing goods that are actually basic needs that we need here in Botswana to continue with lives.
So whilst you're moving to the next slide, you don't quarantine them? Do you just test and follow up, or do you quarantine them at the border, or how does it work?
It has been a very difficult task to actually handle. What has been happening is that it would be depending on what they were carrying. Some of them would actually, who are bringing goods to Gaborone, they would be escorted straight to where they are to drop off the goods. They will deliver the goods and maybe go back to their country. And some of them would be traveling through, so they would escort them and hand them over at different zone areas to security officers who are actually escorting them to those points. But some are actually quarantined and wait for the results. So it actually depended on what actually they are carrying. If you are carrying perishables which would go bad in a short time, the best thing is to ensure that they deliver them in time.
True.
Mm.
It's very challenging.
Yeah, it was a great challenge. Yes, it is. Even now, it is a great challenge because sometimes we try to keep up with the turnaround of 72 hours, but sometimes it doesn't happen like that, and it's a huge challenge. So the other duties in other healthcare centers, we're ensuring that there is continued care of chronic diseases. For example, we have a clinic at Block 6, which continued, which is a diabetic clinic. It continued running. We ensured that HIV clinics continue running, and also that there are actually doctors placed at other clinics where are not termed as COVID-19 centers, so that the care of other patients also continues. And also we ensure proper referral of suspected cases to COVID-19 care and quarantine sites. So actually you would have people being scared of going to calling the call center and saying that I think I have COVID-19. So those ones they would actually go straight to the clinics, and that's where we also ensured that they are properly handled and referred as appropriate.
So has this impacted on chronic care in terms or general services at the primary care clinics? Has the response to COVID created problems for normal care?
It has actually, like I mentioned, we had the lockdown, for example. We had the lockdown, and it was difficult for people, some of them, to access to keep up with their usual appointments.
Right.
Issues of not having public transport, which was also on lockdown. So we had people actually not going.
Can you hear me?
Appointments, and also I think Botswana is as a country, it's with shortage of healthcare providers, having to pull up some people, some of the doctors or some of the healthcare professionals to be at an area like at the borders and also at isolation centers, being there 24/7, taking care of those areas. It was a challenge with those on the ground, that then there were less people actually providing chronic care, but we tried the best that we could.
So I see that it's, I think, opportunity for Sandra. Is Sandra going to talk about Ngami?
Yes, Sandra is going to talk about Ngami.
Welcome, Sandra. Sorry, we've been, you can speak, Sandra, about what's going on in Ngami. Good, we can, I think you are all unmuted. You can go ahead, Sandra. Hello, Sandra. I think Sandra's challenged somewhat. Mpo, perhaps you can continue with the slides until Sandra comes on board.
Okay. Okay.
Sandra, are you able to come?
Can you hear me, Prof?
Yes, now we can hear you. Are you okay? Do you want to take over? Go ahead, Sandra. You're unmuted now, Sandra. We can hear you,
Can
Sandra.
you hear me?
Yes, we can. Go ahead. Ampo, I think let's leave Sandra. She's struggling, so perhaps you can carry on. I'll just manage Sandra talking to her.
Okay. Okay. Ngami District Health Management Team, that's where Sandra is based. So after the announcement by the President and the Presidential Task Force, there was a mobilization of District Disaster Management Committee led by the District Commissioner in Ngami. And they also was sensitization of leadership at full council meeting. So when the councillors had their own meeting, they were actually sensitized and educated on COVID-19 and what strategies would need to be put in place in order for prevention of COVID-19 in the country as a whole. And risk communication was disseminated. Risk communication was communicated, and there was dissemination of strategies to communities in Ngami area, which I said it's the Maung zonal area, as you had seen in the map that I showed earlier.
Mm-hmm. So Impo, we'll have to manage time a little bit carefully. So is the situation similar or different to Gaborone? So
Yeah, it's almost similar. The family physicians in Sandra, the family physician with others who are in Ngami, were leading actually IPC strategies. They were training healthcare workers on PPE. Even this morning she was training some. She trained some yesterday. This morning she was training at the end. That is why maybe she couldn't really get to set up well on time. She was training people this morning and this afternoon. And they were also, what they did is that during contact tracing, as they were going door to door and also sensitizing the nation and the community, they also included other primary care initiatives. They ensured that they kept on running, like distribution of condoms. People were locked down. It was difficult for people to go. Things like distribution of condoms. Things like high impact, these things for under 5 malnutrition management strategies. They actually ensured that the under 5 were getting what they are supposed to get at their homes as they were doing contact tracing. So, and they were ensuring that chronic care clients were getting medication for a longer period of time than usual, instead of having to stuck at home without getting medication on time. So those were the ones that actually were maybe a little bit different from our setting here. But as for issues of testing and swabbing, the other things that I
very
have
much the same.
Pretty much the same, yes.
But all those things you've just mentioned are actually very important roles at family physician and the responses on the ground. Perhaps we can scroll through quickly the slides and we can come back if Sandra can add some comments again later. Maybe we can just move to Maralise. If they're very similar, she can just point out some of these little details you've mentioned, just enhance them a little bit. But how she sort of made sure that services remained intact and did not crumble, which is really very important. Can you move through to to Marale's presentation?
Looks like the slides are stuck now. I don't know what.
Yeah. What you do is stop sharing, and then I think if you, there it is moving. There we are. Seems to be moving faster.
So they actually formed different teams, and like I said, family medicine was at the top of infection control. Yeah.
Right. Good. Good.
They also set up a call center where they actually developed, they would talk to people, give them messages. They also collaborated with
local comedian. That's really interesting. Please share that video with us.
I don't
Please
know
share
if
that
she has
video. I hope she can share it with us.
Sorry?
Hope she can share it with us. We'd love to share it. Even if it is not understandable, I'm sure we can work to try and make some sort of subtitles, and ensure that people understand it.
Let's hope Sandra has any. I don't have any of them with me. So
she must share it with us so we can put it up and let us see what wonderful work you're doing.
Okay.
Great.
All right. So even there, they had one of the family physicians just based at the site, ensuring that chronic care lines are continuing.
Yeah. Chronic care is a real challenge in this setting, being both high risk and in themselves things you need to keep going, make sure the services continue. All right.
Yeah.
We'll come back. I think that Sandra will get a chance to just speak to them briefly, some of the issues that we might have glossed over. Let's go to Marlies, and then we'll open up for question and answers. Marlies, do you want to speak? You can unmute yourself and present, and Paul will take your instructions on moving to the next slide.
Okay, thank you very much. I would like to highlight Sandra has sent some messages, been unable to hear us from the very beginning.
Yes, and she's challenged, I can imagine. Yes. So let's not stress her too much. But thank you, Sandra, for trying. Are you ready, Marlies?
Yep.
Yeah, you can go to the next slide. Marlies, you can speak. Paul?
Hello?
Yeah, Paul, if you can just move to the next slide.
Okay. All right.
There we go.
So we try to give a little bit of background about family medicine physicians or family practitioners. Just to know, we are a primary care physicians who treat all age, hence the term of family medicine, from the pediatric through the geriatric age. For everyone is well known, family physicians help to manage and diagnose a variety of common illness, especially chronic conditions, acute conditions, covering a broad spectrum of health issues. We do take care of all conditions such as diabetes, asthma, hypertension, heart diseases, hyperlipidemias, depression, HIV, gynae conditions, surgeries, etc.
Paul?
Paul? As a family physicians, we emphasize mainly the prevention and education of our community. During this period, one of the main objectives of our job has been to the reassurance to maintain a low level of anxiety in our community due of the circumstances we are living at the moment through this pandemic.
Next.
In our facility as a private sector, I would like to give an overall of how family physicians we have been involved. Actually, in our hospital, we are two family physicians, Dr. Malone and I. In our institution, we have information campaigns supplied by MOH and Wellness LandMed Office, and as well by the government. And we try to perform, we have, as a family physician, we have been performed training on all our staff based on the use of PPE, donning and doffing, the hand hygiene, and we have been performed drills to see how a team will act in different case scenarios. We prepare basic information about COVID-19 for non-clinic and clinic staff. We did sentinel testing, which started from the very beginning with pre-op patients only. Thereafter, with staff and patients living in areas where positive patients were identified. And most recently, we have extended to all admitted patients in our hospital. We created a COVID-19 committee with weekly meetings, and we have a multidisciplinary team involved in our meetings just to discuss the news, how to perform better, and how to train the rest of the people around, and how to be able to support the community and the country in this difficult time. We perform a daily screening at the entrance of the hospital. We have a questionnaire and the temperature testing, and we took, it was a very good impact in our setup. We also took the advantage of not allowing visitors in the hospital for inpatients, except to ICU, where one visitor per patient was allowed, and is still allowed for a period of 1 hour and only one visit during the day. All entrances in the hospital were locked, except for the one corresponding to the emergency room, which is controlled by security guard 24 hours a day. We implement clinical guidelines for management of different patients in different scenarios in Bokamoso Hospital, where developed based on the guidelines established in Botswana, in South Africa, and the ones provided by WHO. Next. We were proud to introduce the use of masks, the practicing of the proper hand hygiene and the social distancing for the entire hospital, which had been applied before the government pronounced mandatory. So in this case, what we did, even for consultation rooms, we allow our patients to keep three or four in the waiting area, and others who were coming before their time, they could have been wait outside in the parking area after the screening was done. So, and this has been working for us very good, and patient has been very happy, and we have been able, for those who walk in the hospital and they don't have masks, we have been able to provide masks for them and encourage them the mask, the use of it. We implemented a protocol for theater, radiology, emergency room, and COVID-19 units. Elective surgeries in our hospital were deferred. Only emergency patient has been carried out after the undergoing COVID-19 test and level 3 PPE. Next. We did something very good in our institution, and that was the introduction of the fever clinic. What was the objective of our fever clinic? It was all patients with temperature of 37.4 or any respiratory symptoms are reassessed in the fever clinic before allowing them to proceed into the hospital. Fever clinic is run by the 2 family physicians in the institution and by a medical officer from emergency department. What do we do in the fever clinic? Okay, in the fever clinic, once we have patients with symptoms, we do the COVID-19 test and we treat all the symptomatic patients and we send them home to self-quarantine until we get the results. And we admit patients with moderate symptoms suspicious of COVID-19 for immediate treatment pending outcome of their results. Once is positive, patients are transferred to the designated COVID-19 treating hospital, Circuit to Milima City Teaching Hospital. In that way, we have been able to allow to provide a very high quality care to those requiring the assistance while maintaining the safety of hospital population, both the staff and patients. Once we find a positive test results, we immediately inform to the DHMT. Next. In these slides, we can observe how we are performing our tests. We perform both of them. We just do the oral and the nasopharyngeal swab. And we know we take our time. We found like it's unpleasant test, but we take our time to explain all to our patients how is the test consists. And so far it's been working quite good, and patients has been able to contribute and respond to the procedure. Next. In this moment as well, we cannot allow to pass the opportunity to thank the National Health Laboratory for the close collaboration, efficient service, and fraternal bond built with our institution. As a family physicians, as a human being and a part of the community of Botswana, we have found this has been a very difficult period. We have been facing a lot of stress, tension, fear, even though we have not managed yet any positive patient. However, we do believe that once the borders open and positive patients present, acknowledging the preparation made, we will be able to treat any patient with COVID-19 through our multidisciplinary team. Keneilwe, thank you, gracias.
Thank you very much. Appreciate that, Marilis. If there any, let's see if Sandra can add any comments, if she's able to come on board. Sandra, I'm going to unmute you, and if you don't touch anything, just speak. I think we hope we can hear you. Would you like to add anything, Sandra? Yes, we can hear you now. Don't worry, just speak.
Okay, thank you very much, Prof. I think I was having a challenge this side because when Impo was presenting, I couldn't get any audio from my end.
Okay, no problem.
Yes.
But we can hear you very well now, so please use the opportunity.
Yes, Prof. I think they have covered everything that we have been doing also on our end. I think I'll comment more if there are any questions or comments.
If you don't mind me asking while we've got you, and I think it's comments that have been made by Marilis and Impo about the impact on normal services. Just a curiosity, in Botswana, do you all have a family physician, doctor, nurse working as a clinical team? How has the family physician supported the team on the ground? Have there been any noticeable impacts of the family physician in that setting with the rest of the team? I know that Marilis says that multidisciplinary teamwork has come along, has come out outstanding. What's your thoughts about teamwork at the clinic level in Ngami?
I think as well for our team, the teamwork has been outstanding. When we initially started our teams, particularly in relation to the case management, it's actually all the family physicians that came on board to join the 3 teams who wanted to work in the isolation center, because we needed to have a doctor and 4 nurses and 4 cleaners for the 3 teams. And all the 3 teams are currently led by family physicians. And in terms of routine clinical care, we also have 2 physicians that were assisting in seeing clients with chronic conditions. But I think because of other engaged policies that were enforced by the government, It also led to some patients being unable to reach out to us, especially during the lockdown period where there was a critical shortage of transport.
Mm-hmm. Let me just ask the attendees, please feel free to add questions to the Q&A. And while you're doing that, I'm going to just carry on with some questions, but we'd really like other people in the audience to share some of their thoughts or questions. Sandra, let me ask you one or two more questions. One is, have community health workers been an important feature in your practice in the clinic setting? As a family physician, have you related to them, and have they played a key role in your response to COVID?
In terms of other healthcare workers, particularly the nurses, we've been there mainly to support them psychologically. As frontliners, we have been having debriefing sessions where people were also able to share their feelings, and it was quite an emotional experience for us, because during those sessions, that is when people managed to really tell us how they felt with this current situation of COVID-19.
Okay. Perhaps, Marilis, you could answer the question, and as well as Simpo and Sandra. You're obviously challenged with internet. I mean, clearly this challenge with Sandra now sounds like more rural communities have a challenge. But have you all used, how have you all tried to manage practice like internationally? People have started going online or using the telephone or looking at other ways with less contact to relate to their patients. How has that panned out? Any one of you could respond. Perhaps, Marilise, you can relate what's happened.
Yes, Prof, and the rest of the audio. It's been a real challenge, but from the very beginning, and especially during the lockdown, we never stopped our clinics regardless. Patients were needed permit, but as you mentioned, we used the tele consultation. Patients were able to consult us using WhatsApp or any other via, so we were able to advise them what to do, conditions, email them the prescription, others like chronic conditions where we knew there were no risk. We were just sending our prescriptions to them and reassuring them to keep safe until the country was open and the lockdown was stopped and patients that were allowed to come in and out. But we never stopped to proceed and assist the community.
Well, that sounds great. Marilis, one other question, and maybe Sandra and Impo, have there been any other, before I go on to the private doctors, any other thoughts? How have you all managed the sort of online space or unconventional ways to manage care? Anything you'd like to share, Sandra and Paul?
I think on our end, having stayed in Ngami as a rural village, I think for us it remains a challenge because we do have majority of our population staying in cattle posts and in areas where we call the wetlands, where you cannot access those areas by road unless if we fly there. Maung is a gateway to the Okavango Delta, so we do have communities which has having very low socioeconomic status. And for us, even for them to just call the call center for advice remained a challenge for them. So for us, indeed, I think our communities were affected in that manner.
Which really says that, if anything, rural communities, hard to access communities, the IT is going to be even more important for decision makers to say, we ought to be making access to them, communication access, a real priority, so that they can even get care, like we are trying to do now for sort of well provided communities. Anyway, it's an important idea for us to say technology ought to help the most marginalized communities. Paul, do you want to respond to that as well?
Yeah, even here in Gaborone, it has been a challenge, and it remains a challenge because our public setting, our public health system doesn't have any service of that sort. And this is something that actually the association is actually thinking of working on something like that. We actually want to go into communication with the Ministry of Health so that we set up a telemedicine in the near future so that we'll be able to
Wonderful.
tackle such, because it remains a problem in the public health setting. We've never
For
been
sure.
able to do that. Even though the telephone networks here actually came across for the government. They actually reduced their tariffs. They actually ensured that everyone could get internet, could get into social media and be able to access any information that the government was disseminating to the population. But
Right.
the issue with healthcare through telemedicine is still difficult.
Well, it sounds great. I think that's the kind of idea, as a new association, just young association, and now one of the newest members of Wonka. It really would be important for you to punch, above your weight and reach out to these stakeholders high up and start advocating for better policies in primary care and emphasizing some of these issues. So that sounds really good. Please proceed, and if you need any support, let us know. I think that one other question I have, I'm seeing a few questions coming through. One other question while we're looking through it is the question of private. Oh yes, here's the one. How did private doctors, Dr. Tumasime from the WHO is on the call as well, and he's asked the question: to what extent did the COVID affect the private facilities? I think he's asked about budgets, which in other words is has it impacted their patient numbers and their income? But has it changed their practice as well? And have they thought of online approaches as well? Perhaps you can share what has been going on in the public service, not just in a setting like Marelise is doing in a big hospital, but in small GPs as well. Perhaps Mpho, any of you can respond. Marelise, you can start, and then maybe Mpho and Sandra can share their insights on small GPs. How has it affected you all in the private facility, Marelise, in terms of your income and patient turnover?
Yes, Prof. And the rest of the audience, as you mentioned, we work in the private hospital. It's a big institution, but we felt the impact. It was the COVID-19 reduced the number of patients coming to the hospital, and hearing from our fellows physicians out there and general practitioners, most of the clinics sometimes they were needed to be closed or working half of the day, and the number was so low. At the point I see economically the impact and financially was very high. So the numbers went down, the income were low. I think it's been a big challenge throughout until the country and us as a community, we have been learning how to deal with the virus and how we should protect ourselves and get the advice from our doctors, our healthcare, and our psychologists or social workers, impact as well with the schools. So I think it has been a big challenge for the whole community.
Good. Just a quick question, Marelise, how much of an impact, if you were to sort of make an estimate, rough estimate, what percentage of patient drop in your hospital? Has it been 50% drop, or what sort of drop has it been?
In our hospital, probably reduced about 40 to 50% of the patients coming in, because due of lockdown also we are unable to receive patients from another part of the country. So the number of patients only moving from the greatest Gaborone and those ones was needed permit. So what we did, we also tried to be a little bit creative. For example, family physicians like my colleague, Dr. Malone, and I, we did create sort of a letter. So when patient was calling and they were needed to come and permit was not granted to them, we were able to email that letters saying they were needing an appointment, and somehow they were allowed to pass through the roadblock where the soldiers were checking each of them. But that, I think, it was initiated by us, and other doctors stood upon the same idea and worked a little bit, but we stopped somehow our elective surgeries during that period. So that is a big impact in the community. We were only allowed the emergencies, and it was with a lot of stress and tension, but I think more or less it's about 40–50% of the impact in our institution, which is quite a big hospital with all kinds of specialties in.
And you said in the private small GP, that's been almost more than that.
Exactly, yeah.
Okay. Paul, any comments about the impact on the private sector? And Prosper has asked two more other questions, which I'd like to ask as well. Perhaps you want to comment on the private, otherwise we can move to the other questions, which you perhaps can answer to. It's a question that Prosper asks about what is the age and gender structure of the COVID cases? Is it mostly male, older, multimorbidity, or are you seeing slightly different, in terms of the cases, the infection? Anything that you have on that? It's a rather few you'll have at the moment, but any thoughts on the profile of cases?
Okay, let me talk of the impact on private sector first.
Yes, yes.
From what we heard from our fellow doctors who are in private practice, it actually, at the time of lockdown, there was actually limited transport, so people couldn't go out. If you go out, you had to actually have a permit. So it was very difficult for people to go to see their GPs. And of note was that most of these businesses, they are in areas where they're actually renting, it's rental areas, and they actually had to pay rent at the end of it. So there was no income but they actually had to pay for the services like the place that they are using. So it has had an impact economically on them, and even some of their patients, I believe, there would be a drawback, like chronic illness patients who have been followed up at the private. Some of them were actually not being able to be seen during this time. So there's actually been an impact on that. And on the profiling of COVID-19 patients in Botswana, I would say most of them were middle-aged patients. They were in their ages between 20 and I think around 45 or so. I don't have.
Young.
I think the eldest that I remember was a 56-year-old, the eldest that I remember. And like I said, most of them had most were asymptomatic, and those that had symptoms were just mild upper respiratory symptoms, and they just were able to recover and go. So we never really had
mostly a traveling sort of profile. Mostly, like you say, imported people who. It was mostly imported, so most of people who travel, being young male, youngish male. Okay.
Yeah. And like that good number are those who are actually transporting goods to different countries.
That's
so
right.
those like the 49 that I mentioned.
Yes.
Yeah.
So those are the people that you are, that's kind of risk profile, that you're having in the country, especially without, I think, community spread. Mostly it's going to remain in that kind of age group. Can I ask the last question before we give Dr. Tumisime an opportunity just to speak, is the question of infections of healthcare workers. Have you all had any so far? And how is that proceeding?
Okay.
Have you all had any healthcare worker infected? None.
None from Mau.
Okay.
None from our setup.
Well, just keep that up. Be safe. That's really important to keep our healthcare workers. We tend to be picking it up and actually from our own backgrounds, which is a real challenge. So thank you for that. I'm going to try and get, any other comments while I just talk to Prosper or just allow him to say a few words as a panelist. So, yeah, any comments, closing comments?
We just had only one. Okay, I was gonna the last question that
Yes, go ahead,
you asked. There was only one reported healthcare worker in Botswana,
Welcome.
and
Okay.
he's long recovered. So
Wow,
yeah,
good, good. Keep it up. I think that's one of our biggest concerns in terms of improvements in primary care with the number of clinics. Is I spend my day more or less trying to, educate community health workers about the risks for themselves and how they need to be very vigilant, even in the tea room in the clinic. And it's a huge challenge to get them to change their behaviors in that kind of space. Well, thank you all very much. I want to close by asking Dr. Tumisime. We're very fortunate. He's the Director of Health Systems at a very high level in WHO Afro. And Prosper, we'd really appreciate if you could just make some closing remarks, perhaps share anything that you think quite useful for us to know. Feel free to share that.
Well, thank you very much again for enabling us to be on this webinar. Very resourceful and showing us what is going on really at the periphery, at the district level. And I'm impressed by the way that this was organized in Botswana by, getting the zones which then would be manned by competent teams, and the role that the family health physicians are really carrying out. I think that's very important. To have family health physicians leading this kind of work at the district level. It's again also important that Botswana managed to contain the infections that came in from outside, and was able to limit that to only a few cases that eventually, well, there was hardly any community transmission, which was very good, I think, at that very moment. What we've seen in other countries is that with the lockdowns, there has been a lot of problems in terms of access to essential services. And I was glad to hear that in this particular case, in the presentations that were made, Botswana was able to somehow continue providing these routine services. In most countries, all of the efforts have really gone into responding to the pandemic, and then the routine services have suffered quite a lot. And we are advocating that in each country that they should ensure that that's a key pillar in the response for maintaining the routine services, and should be done right from the beginning and not as a by the way. So it's important that is happening. I also want to point out the collaboration that came in the presentation between the private sector and the public sector, because I think there was a mention of the National Health Laboratory being very, positive and working together to respond to the needs of the private sector. I think that is the way to go. We really cannot now move away from the private sector. We really need to find ways to engage them. We need to find ways to explore their comparative advantages and use those to not only now to fight the COVID, but even when the COVID goes, to really help us move the health agenda forward. And it's only when we combine these efforts that we can really move together and make a good progress towards achieving our targets for the SDGs. So again, just to say thank you very much, and I appreciate the work that is being done by our colleagues on the ground. Thank you so much, Prof.
Thank you, Prosper. Just a quick question, Prosper, in terms of just a broad issue. How is the COVID and the UHC efforts being managed, you think? Is there anything that we need to be aware of that the WHO Afro is advocating at a government level to advance the cause of primary healthcare UHC within this COVID response? Is there anything you think we should be aware of?
Yes, I think we want to really go a little back and say that the countries in Africa need to learn from the past. And I think that has been a bit of a problem. We've had other epidemics, for example, ravaging the countries and the health facilities and the health systems almost to a halt. And once that happens, lots of efforts come in, lots of resources come in, deal only with the emergency, and as soon as the emergency comes down, then that's it, and the rest is forgotten. And then we'll wait for another risky period when again another epidemic comes. So I think what we need to learn is that the strength of the health system is the core of responding to any health threat or emergency. If your system is strong, then you are more likely to respond better and possibly respond earlier, and therefore be able to save more lives. And I think we need to advocate not only to the governments, but also to the donors who give us support, that there should be a lot of stress on investing into the system as well, so that we can forestall the dangers that would otherwise come later on. So UHC is an agenda that should be moving. Even as we have the epidemic, we should, at the back of our minds, know that we are looking at a bigger picture. And this is just part of it that needs to be integrated into the whole apparatus of moving towards UHC.
Yeah. No, thank you for that. I think that's exactly the end point we need to work with, is that as we proceed now, we need to, in responding to into COVID, try and highlight, in Botswana, in every other country that we come from, to pitch the idea that COVID is showing up the cracks and in our health system. And in that crack, we need to say the cracks are universal coverage, integration with public and private, and a way in which primary health care actually gets to be the center of this approach. And I think, as everyone has seen, a great deal of wonderful work being done on the ground by primary health care teams, led by family physicians, and also a very supportive WHO. We, in fact, have been facilitating an engagement between primary care organizations and the WHO, and Dr. Tumisime has been facilitating that from WHO Afro. So we really are very pleased with the support we have. A lot of the onus now sits on young organizations like the Botswana Association of Family Physicians, young people, young leaders like yourselves, to be able to make sure that things can happen in that small space, and that we can make sure that health for all is not just a pipe dream, it's a reality. So with that, I want to say thank you to our panelists. That's Mpho Mpape, Sandra Maripe, and Dr. Tumisime for joining us. And lastly, Dr. Marales Gonzalez. We really appreciate you spending our time. And to all our attendees, thank you very much for joining us. I hope you found this quite useful. We're going to have another webinar next week at this time on Zimbabwe. And we really hope to get a good idea of what those people are doing, those wonderful colleagues of ours are doing on the ground. With that, I wish you all well. Enjoy your weekend. Please be safe. Bye-bye.
Thank you.
Thank you, and bye.
Thank you. Thank you, Prof.
Thank you all. Bye-bye.